things around all of this that have changed us or have enabled us to, be who we are. And then also still navigating these obstacles. And I know myself personally, after being diagnosed with breast cancer, that's been a huge identity shift for me as well. And so, I think talking about identity and access and care and like all of like the language in which we're talking about breast cancer or transformation or pride or just access to care, especially in the kind of stressful climate that we're in right now currently, I think is really important. So again, this is my long intro to say thank you so much for being available tonight and joining us. That's a little bit about me. Elegie, would you like to introduce yourself and where you're calling from and a little bit about your background?
Yeah, for sure. I am Elegie, and it's actually pronounced like Ella G.
Okay, so my
And
accent is wrong.
yeah.
Okay.
I work in retail. Sanjana and I actually worked together at Apple when I worked at Apple in Washington, D.C. And I am a rights advocate for those in the trans community, as well as an activist in my own right, and just a person that works.
Yeah, absolutely. Wonderful. Well, thank you for joining us tonight.
Yeah.
Elegie. Am I saying that properly? Elegie.
Yep.
Okay, wonderful. And Chelsea, please introduce yourself. I see some guitars in your background. Are any of those Fenders? I don't know. I try and be a guitar player, but I'm not really good.
Yes, I think so. I think this one is a Fender Squire.
Awesome.
They're my partners.
Excellent. I know I like taught myself off of YouTube, so like I'm very amateur, but I get excited when I see it.
Yeah, it's always like brought up in Zooms now with like everything being on Zoom. It's like, what's your background? And those always get attention.
Yeah, exactly.
Which I think is why my partner put them in the frame. To be like, oh yeah, those. Yeah, I play.
Absolutely. She gets a shout out. He or
Yeah.
she. Yeah. So tell us a little bit about where you're calling from and your background. I know you're very prominent in the film industry, which I'm excited to hear about.
Thank you. So my name's Chelsea. I am a non-binary femme, bisexual, queer, living in Brooklyn. I'm originally from Tennessee. I've lived in the city I know, Elegie, where are you from?
I live in Memphis.
Oh, you live in Memphis now?
I live in Memphis.
I was born in Jackson, Tennessee.
Okay.
Yeah, so like right outside of there.
That's awesome.
That's so funny. So originally I'm from Tennessee. My family still lives there. They're in Chattanooga. But I've lived in New York for about 13 years, and I currently live in Brooklyn with my partner and my dog and my stepcat. My paid work is working as an art department coordinator. So I kind of like just coordinate everything that's needed for art departments in film and TV, mostly in television is what I work in. And then my unpaid work is producing films. Mostly they're all queer stories and mostly documentaries is what I'm working in right now.
And so I think right off the bat, I need some definitions of terms, right? So you're in your introduction, you mentioned that you identified as non-binary. Let's start there. What does that mean?
It just as the word like binary, like male, female, and then not that, or also like beyond that.
Okay.
So like not male or female, I feel I always felt more like alien, and this is me defining it for myself. Just always felt outside of either thing. So non-binary and but femme is the other part of my identity, or like is part of that identity, which I discovered like only in the past like 5 years by like my work and like existing in like Brooklyn queer nightlife and being around drag performers and burlesque performers and where those things collide and intersect. And they've really, different members of that community really like are these really empowering, strong, vulnerable, dynamic femme queers. And so yeah, that's part of my like not a woman, not a girl, but like femme. I'm still non-binary, but I am femme.
I love that. We have done a huge fundraiser recently, actually, with doing a burlesque show, because I feel like those after being diagnosed who want to come on stage and do burlesque is just this moment of like empowerment on stage to say breast cancer is not going to define me. And here we are showing and strutting our stuff with everything. And so I completely agree that, you know, the lines can be a little blurred depending on what communities we're talking to and who we're speaking of. I just recently got off of another Zoom call, and I would love for you guys just to comment on this, because this came almost as a surprise to me. So, you know, I work in my day job, or as you mentioned it, my paid job. I actually work in education, and so we're going through this whole shift around diversity, identity, and inclusion and equity. And so there are all these modules and all of these trainings that we're going through, which I really appreciate. And then, you know, it's almost like we enter the conversation of what are your pronouns, which I was being taught in these training modules of that's the best way to enter. Like, I don't want to make assumptions. So, what are your preferred pronouns? And I just got off of this call saying that is the most inappropriate thing to say to somebody, because in a medical setting, I want to focus on my medical health. I don't care what you call me. My name is Laura. That is how I identify. And so, excuse me. I just thought that was such an interesting take from someone's perspective on pronouns. I don't know if you have any reactions to that, either of you.
I've been in a lot of environments where there's a lot of focus on pronouns, and you know, some people will tell you that their pronoun is their name, similar to what you're saying. So it's more so that your pronoun, you don't care about pronouns, your pronoun is your name, and that's what you want to focus on. I think in a lot of healthcare settings, I've been in a lot of situations where I've been misgendered before, so there has to be more focus on pronouns, even if it's not necessarily for myself, maybe for that next person that walks into the office, to make sure that they're paying attention to that and their care to someone else. I've even had that happen to me in a LGBTQ health center. And while I was in the office at the same time, someone was dead named. So there should be a focus on correct pronoun usage and correct name usage, because on more than one occasion, someone has come and gone, Mr. Brooks, in the waiting room, and you're like, no, that's not correct.
Right. And for our listeners and myself included, what would dead name mean?
Dead name is your either legal name or previous legal name if your name has already been changed, and not your chosen name.
And I think that's such a good point too. And you know, to relate this also to the breast cancer community, language is so sensitive. Like, I, having started this organization, I call it surviving. It's like a present tense thing that we're doing. And I have people who are diagnosed with metastatic breast cancer come to me saying, well, I'm not surviving. Like, I'm not a survivor. I don't identify as survivor. I'm like, no, I'm not calling you a survivor. Like, you're still going through active treatment for the rest of your life, basically. But we are surviving, right? So it's kind of like having to defend almost our identity or our preferences or our, like, we're constantly at this fight. You know, and then I was like, well, maybe we're thrivers, like we're just thriving. And they're like, well, we're not thriving all the time either. I'm like, gosh, okay, fine. So we are a person diagnosed with breast cancer. Like, that's what we are, right? So like, what is the best language? And then I talk to other women who come on the show, and I love them because they're like, oh my God, we're warriors and we're survivors and we're fighting this fight. And I'm like, why is it a fight? Why do we have to fight all the time, you guys? So I say all of this because with a smile and a little bit of humor, because at the end of the day, it's personal. And so I just want to start the conversation also with like, what is the language in which we should be for today's conversation be utilizing? If I go off cue or anything too, or likewise to you, if you're referencing something around breast cancer that doesn't rub me the right way, like, this is just a conversation. We're not out to like hurt or offend anybody. You mentioned, Elegie, a little bit about this transition and transformation, and you know, some confusion sometimes in a medical setting around your gender. Can you explain that a little bit more?
Oh yeah, I've had medical professionals misgender me. So obviously when they walk out into a waiting room to call their next patient, they're looking at who the next patient is. And they haven't necessarily taken the time to see that, yes, my insurance may still have me listed as male because that biological marker has not been changed. But I wrote on every single document that I submitted to you, it is Miss, you know what I mean?
Mhm.
So it's that attention to detail by our medical professionals. And I think that that's sometimes what we are lacking in because of my being transgender, there's also other things over time that have gotten overlooked as far as, hey, these are some things that you should be aware of moving forward in your transition that could lead to increased risk for breast cancer moving forward. Hey, you can't go and get like a regular mammogram. You have to get a sonogram, things like that.
Exactly. And I think all of us have a story or two of where someone, to the doctor's ends, right? Like they're just back to back with appointments and it's not giving them credence or permission. But so many times they don't read the charts, they don't read the details. Um, from somewhere where it's like, you don't even know your stage of cancer of your diagnosis and they just assume you already know, and so they're already jumping ahead with treatments and you're just there in shock. To gender, I actually, it's so funny you said that. There were two Lauras in a waiting room once and I got the wrong chart, like to fill out the, fill out your name and the 10 questionnaires, and I'm like, I don't have half of these, but I feel bad for the person who got mine thinking they have breast cancer, So it's like small little things like that too, where it makes such a big difference on the human experience and really just our experience with medical professionals, and for us wanting to build that trust with them so that we can disclose how we're feeling and actually get help and services and prevention care for what we need.
I'd love to dive in here really quickly. So, Elegie, you mentioned, they don't read your pronouns on the chart. They kind of go with what your biological marker is, and you've told them multiple times what your pronouns are, and that's kind of overlooked. And then Laura, that it seems like that's happened with you too. So beyond pronouns, what are some ways that you think would be helpful to, one, make you feel more included and really address you like you'd like to be addressed?
Yeah. So I would say, the last time that I had an issue with this was actually before my legal name change. So I haven't had that experience since then. From a current perspective of where I am now, I do think that kind of going back to what Laura said earlier, making sure that you're using the correct name for someone when you address them in a medical setting. And yeah, if you're using the correct name that that patient has given you, you don't necessarily have to use a pronoun. You can come out and say Elegie, and then I'll know you're talking to me. And it doesn't matter who you're talking to or what gender you might have in mind, because that's my name regardless.
Yeah, I think it goes to like, what is the use of this piece of information right now? Like being called to a waiting room or being addressed for billing or at the desk or something, you don't need to know any of that personal information. It's just, here's my name and we can just discuss it that way. And then, if you're being specific, like in a medical thing, in the medical office, like being specific about the language that you use. Is it woman, man, or is it a biological thing? Is it a risk because I have a penis or ovaries, or, just being like, what is it that you're actually asking? Because the other language isn't necessarily going to give you the information that you're actually looking for, which is going to help all of us.
So Chelsea, I understand you were also diagnosed with breast cancer. Is that correct?
Yes.
And how did you find out you were diagnosed with
So last spring, so spring of 2020, I noticed like a difference in my right breast. And just kept an eye on it, didn't want to freak out or anything. And then COVID happened and just didn't go to the doctor. And then in December of 2020, I noticed a significant difference in the size of the lump. And so then I was like, I have to go to the doctor now. So in January, I went to see my general physician and brought it up, and she sent me to get a sonogram. She was like, you're too young, but we'll send you for a sonogram, you know, the whole this, but this. And then I was in the doctor's office for the sonogram. They were like, you're too young for this sonogram, but we're giving it to you. And then they was inconclusive. They were like, we're going to try and get you in for a mammogram. They held me in the office. So I was like, oh, this is probably something. Had a mammogram, still unsure of what it was. So then I had a biopsy, and that's when they determined that it was DCIS in my right breast. Originally, it was going to be a lumpectomy with radiation as treatment. And then I went in for an additional biopsy, an MRI-led biopsy, and they found another portion of DCIS. So I had a mastectomy.
What was going through your mind at this time? Like, obviously you felt something, so you're monitoring it, which is great. Did you tell your partner? Did you tell family and friends, or what, did you keep this close to the vest? What was going on at the time?
I only spoke to it with my partner. They were helping me, just kind of like, is this different? Yes, you know, just kind of being like, am I just like freaking out about something? So they were helping me like talk through it. I had not had a great experience with my previous doctor that I'd had, so they helped me find like a new doctor. Them and a friend helped me find a new doctor, which is who I started with in January, like a general practitioner to like be like, okay, this is I need to like get this addressed. So yeah, I kept it just between my partner and myself.
Chelsea, can you tell me what DCIS is?
Yes, it's ductal carcinoma in situ. I think I said all those words correctly. So yeah, so it's in the milk gland. It's in place. So in situ, it's like in the place that it is held in. It hasn't become invasive yet. But there are cancerous cells in the lining of the milk glands.
Yeah, so that's a really great point. So a lot of times with breast cancer diagnoses, you're looking at either like ductal or invasive, right? So is it in the ducts, or has it invaded and gone beyond the ducts? And then even if it moves beyond the breast tissue itself, it could potentially go into the lymph nodes, which is just one of the passageways that the cancer can maliciously go to other parts of your body and become a metastatic diagnosis if it goes to your lungs or bones, liver, organs, brain, etc. That's a great clarifying question. Lots of acronyms we use in all of our communities, right? So that's a really good point too. So you were ductal carcinoma, so in the ducts, and opted for, because they found multiple lesions, opted for the mastectomy. And so were you presented with various options for the surgery?
So yes, everything went super fast. It was kind of a condensed and also overlapping from diagnosis to procedure. I always have to keep my dates. So my first biopsy was on February 4th of this year. And then, so I was officially diagnosed on the 11th of February. And then I started meeting with my oncologist, and had one meeting, decided lumpectomy, radiation afterwards was going to be the thing. Then she was like, let's send you for an MRI before surgery. So a week before my surgery, I had an MRI, or maybe like a week and a half before surgery. So I had an MRI. That's when she saw potentially a second place. So then I had the MRI-led biopsy, which was the Thursday before my next Thursday surgery was scheduled. So over that weekend, my diagnosis changed, or I guess my diagnosis changed, but the extent of it shifted, and as did my options. I basically had all of the options, which was great and terrible. Exactly. It's like, I don't want the choices, but I guess it is nice to have them. So my surgeon, or my oncologist, was still comfortable doing a lumpectomy, when we discussed it and having radiation afterwards and seeing where it went. She also said, you know, I was like, mastectomy is an option. And then, you know, I could have done a double mastectomy as well, for reconstruction. Most from, I don't think I had got my genetic results yet, but or maybe I had. No, I hadn't yet. But anyway, I didn't have a family history of breast cancer. So there wasn't a preemptive risk of removing both to get out of the way. So it would have been for symmetry, reconstruction wise. So I sat with that over the weekend, and then I met with my oncologist on Monday to have a final meeting. And at that point, I was like, I just want to have a mastectomy. I didn't feel like a lumpectomy was going to be enough, just my feelings about it. And we sat there and talked, and she, by the end of the meeting, was like, yeah, we should do a mastectomy. This is a lot more cancer than what we had thought. So that was my decision. And then I met with my plastic surgeon on Tuesday, and my surgery was on Thursday.
Wow.
Yeah, so then so I had all of the like surgery options, and then I also had like kind of all of the reconstruction options as well. So my surgeon initially went in and was talking about implants. That was kind of like her opening thing and everything that she was talking about. And I was like, I kind of didn't feel like I wanted an implant. So I was on my own research and talking with other people who were going through similar process. I felt like I wanted a flat closure or DIEP flap.
Mm.
So we kind of talked about like what that would be as far as like how much time in surgery, what's the recovery like for each of those things? Was I even a candidate for DIEP flap?
And so let me just pause there too. And I commend you on the aesthetically flat closure piece, because I think that is something that we don't talk a lot about in the breast cancer community, nor is it something that's always presented to us. And we're trying to work really hard on letting surgeons know that, okay, we have breast cancer and our breasts don't always really define us as being feminine, right? Like we don't necessarily need to have implants. And so if we choose to have potentially less surgeries, or because I think that's a big question too. You get diagnosed, or you're going through a transformation, or something is happening. And I don't know if this happened to you, Elegie, about how many surgeries are actually involved in this process, or how, like, what is the actual timeline, right? So I think, speaking personally, it's like, is it one surgery, you get the cancer and I'm done? Or is there expanders that get put in? Are there implants that get put in afterwards? Are there like follow-ups to make sure that things are even, quote unquote? So, you know, I think there's a lot of, and do I want to put my body through all of that? Like, one, it's a lot to go through just the shock of a diagnosis, and then to deal with the aftermath of all of the surgery and healing and risk for infection, I think is a huge piece. So I think that's really wonderful, Chelsea, that you did your research enough to know that flat closure was an option. And the reason why that I'm stressing that too is because just Googling like going flat or flat closure, there's a lot of horrific pictures out there on the internet. Well, as we know, the internet definitely shares the worst of the worst with any sort of Yelp reviews or anything like that. But, you know, I think when you're talking about, I'll just put it out there, it's not a boob job. It's amputation. You're getting breast tissue removed from your body. And in doing so, you're literally removing the tissue in the area that would hold an implant if you were just getting breast enhancements or a reduction or something along those lines. So what does it mean when you have extra skin? How do you aesthetically make that look like it's closed in your example?
Like you were saying, it's so many choices, and the diagnosis itself was so fast, and it was overwhelming, and I just needed to have the surgery and do the simplest option for me, which is what I finally came to. Like, I just need the simplest thing for like my own well-being right now. And that's why I kind of ended up going with a flat closure. But DIEP flap is a microsurgery. It's micro something, microvascular, I think is the correct term, but
it's a long acronym.
Yeah. So it's taking tissue and fat from another part. For this is through your abdomen, and then forming that as like, instead of an implant, as like creating a boob, a breast for yourself. So it is your own like blood vessels get reconnected. It's quite an intense surgery, but it's quite amazing results afterwards because it's you don't have the implant that is filled with, like saline, I think is mostly used for implants. It's your own tissue. So it's your skin. It feels like your body still.
And the
But yeah.
recovery process too, right? So you're not talking just about getting surgery on your chest, you're talking about surgery in your abdomen, the
Right.
recovery process, etc. But there
Yeah,
are
so-
options, and you were presented with several of them, which is great.
Yeah, I mean, I think it's really about like advocacy for your like self-advocacy and understanding like as overwhelming as the information is available online and how hard it is to decipher things when you're trying to just figure out like what your diagnosis means. But yeah, like I went into it saying like, I'm interested in talking about flat closure and DIEP flap because I don't think that those options would have been presented to me. When I brought them up, my plastic surgeon was like, yeah, let's talk about them. I can do it. This is what my other results are, blah, blah, blah. Like it was no problem. But it wasn't going to be presented to me, I don't think, except that I asked about it. So yeah, like there is so much information, and I understand that doctors just don't want to overload you with so much stuff. But it is unfortunate that, you're not just given like a rundown of all of your options at the top of, or at least that was not what was presented to me.
I think sometimes people have a issue with like intersectionality, and what I mean by that is like people are okay, for instance, like giving money to a homeless person, but when they find out that the homeless person has a drug issue or got kicked out for some reason or something like that, then it's like, then they no longer want to give the homeless person money, but that homeless person still needs money. And I think it's the same thing within the trans community sometimes, as far as like surgeries and things like that. Well, I don't want to give a trans person money because they're just going to spend it on surgeries. Well, yeah, that's a big part of transitioning. And I think that what I kind of took away from part of what you said, Chelsea, is like somebody was talking about, oh, you get a tummy tuck because you had cancer. Great. And it's like, you missed the point.
Yeah.
Can you tell us a little bit about what the transition process was like?
There's a ton that goes into transitioning. There are a few key places where it really does tie in to risk for having breast cancer. My process was pretty like straightforward. I started transitioning a little bit later in life. So I think I was in a place where I didn't care as much about the stigma and things like that. I was just ready to do what I wanted to do. I got to a point where as I would pull up to work each day, I would like start to have an anxiety attack. And I just called my bosses one day and said, hey, I'm not coming in. I don't know when I'm going to be back. I'm going to take some time and figure out what's going on. And less than a week later, I was in an office with a gender therapist. And I was talking to that gender therapist about the things that I was feeling and what was going on. And about a month after that, I was in a doctor's office getting put on hormone replacement therapy. And part of that is the luxury of the location that I was in, because I was in DC at the time. So there are many more providers and open providers there versus some areas in the country. I've talked to some people in like Georgia and certain parts of Tennessee where they don't have access to that kind of healthcare. And a few years later, after having gone through some very interesting situations, I finally found a doctor who I trusted enough to have breast augmentation surgery with. So I went through a implant surgery, and what they did was they actually moved the fold of the breast. Part of that process was the doctor actually discussing with me, hey, you probably don't want to get this kind of implant. You probably want to get this kind of implant. And part of that had to do with autoimmune and potential risk to cancer as well, based on certain kinds of implants. Whenever you start hormone replacement therapy, having additional estrogen in the body increases your risk for getting breast cancer, which I'm sure was told to me at the time, but not in a way of, hey, it actually increases your risk by like 30-40%.
I actually opted not to preserve my eggs. I was like told literally, you have cancer. We need to start chemo right away. It's very aggressive. But if you want to get like I was diagnosed at 34, and they were like, if you want to have children, we can, have you talk to someone in fertility and start harvesting your eggs, but we'd have to actually shoot you with the drugs that actually feed your cancer. And I'm like, well, I guess I'm not having kids then. Like, let's just start the chemo. Like, you're not really giving me a choice, right? So it's scary. But I think also at this time, you're so focused on this transition, it could also, just like in cancer, like it's in one ear out the other. We don't always necessarily take in the risks that are being told to us, almost boilerplate. Here's the laundry list of risks that we need to be aware of. And just like any pharmaceutical company, there's the risk of suicide at the end, et cetera. Right. So like, we just kind of listen to it, and it goes in one ear out the other. And I think it's after the fact. I don't know if this resonates with you, but almost like after going through something that it hits you, everything that you've just been through. And so, Elegie, please continue. I didn't mean to interrupt and interject with that.
Oh, no, you're fine. I something that you had just touched on, I was going to speak on, and I can't remember what it was now. But the other thing that I was going to say was, I don't remember being told before my breast augmentation, like, hey, after this, you're not going to be able to get like just a traditional like mammogram, right? You're actually going to need to go and get a sonogram done. And I'm sure that wouldn't have affected my decision, you know what I mean? Okay. But it's just for awareness of others, like that should probably be a discussion that happens.
Absolutely. Exactly. What's the screening protocols? What's the follow-up? What is my new healthcare plan? Right? Like, there's, especially in the US in our system, it's like you hit these age milestones, and that's when you start to get screening. And Chelsea, I was hearing you too, like, oh, we're too young to get cancer. Like, we don't even screen for breast cancer until 40. And so, where does that leave us in that spectrum? Can I ask what hormonal replacement therapies you were on?
So I take estrogen and spironolactone, which is a testosterone blocker.
And are there side effects associated with that?
I mean, whenever you take hormone replacement therapy, there are side effects. What it is for most people that are transitioning, what they think about are the positive side effects that they're looking for, where you have fat transfer and fatty deposits develop within the body, glands develop within the body that you didn't have previously, getting like more soft and supple skin, things like that. Things that I probably signed off on, but don't remember a doctor ever talking to me about was, hey, when you get on a testosterone blocker, it can cause massive weight gain. It can cause significant depression. It can cause all kinds of stuff that I wasn't aware of and just recently found out about, I would say like a year or so ago through independent research. And I was like, I'm going to reduce the amount of testosterone blocker that I'm taking.
Yeah, absolutely. And how long ago or current, like when did all of this take place? Are you on these blockers for the rest of your life?
So yeah, whenever you start HRT and you're on hormone replacement therapy, even after transitioning, you'll still be on some form of HRT. It may be reduced, but you would still be on HRT because at that point, your body is no longer creating those hormones. For instance, if you are a transgender woman and you're transitioning to become a woman and you remove any like a male genitalia, you're no longer producing like a testosterone of your own, or even some estrogen of your own. You can get like estrogen replicators or things like that, but you're not producing as much of your own anymore. So that still has to kind of be supplemented.
In the breast cancer realm, we talk about a lot of the hormones, especially because, as you were mentioning, the estrogen higher doses of it can lead to potential breast cancer. Chelsea, do you know the specific characteristics of your particular breast cancer?
ER and PDGR positive.
And are you currently taking any hormonal therapies?
I opted to, based off of my genetic rundown, I opted to not take the blockers because of the side effects.
Yeah.
I just didn't, there wasn't a huge reason that the doctor could give me to take it for risks, for preventative. So I opted not to, so I didn't have to go through all of that.
Yeah, no, I empathize. I love your positive spin, Elegie, on the positive side effects. I need to reframe that because I am taking letrozole actually, along with a Lupron shot, which reduces the estrogen produced in my ovaries as well as my adrenal glands or wherever else estrogen is produced. And I'm so glad you touched upon the mental health piece too, because when you deplete your body of these hormones that we're born with, like the chemistry is actually changing in our bodies. So
Yeah.
I joke all the time. I'm like, I feel like an 80-year-old woman. Not that there's anything wrong with being 80, but like when you're like in your 30s, I'm like, I feel like I'm 80. And the doctors are like, well, biologically, you kind of are. Like, we've thrown you into menopause. We are giving you all of these hormones. You're gaining weight left and right. You are at risk for osteoporosis. You're like, it's like, gosh, like,
now that you mention it, I was actually just thinking my cousin has had a hysterectomy and has had I think partial mastectomy because of early indications for breast cancer based on estrogen. And also speaking about that hormone replacement therapy, she just recently had to go from Tennessee to Ohio to have hormone replacement therapy pellets because they actually do pellets like underneath the skin on your backside. And that was like the best option for her because she had a previous doctor who said, well, you can take this kind of hormone replacement therapy. And she was like, well, I've already had a doctor tell me not to do that.
Chelsea, I love that you selected to go flat. And then also, Elegie, you were talking about how you went through and went with implants. And so how do each of those choices, what do they, maybe it doesn't even center into your identity or thought, but I would love to just kind of hear a little bit more explanation about the role that, I guess, breasts play in our lives, like if I could even say it that way. Yeah, so for me, so I'll put myself out there, when I had quote unquote the luxury of going through chemotherapy first. So I had 6 months of terrible treatment, losing all of my hair, losing my eyelashes. I have all the hair on my body, the good and the bad hair. But it also allowed me 6 months to do the research on surgery. And so depending on the day, I was like, I want implants. I have a very small chest. So I'm like, let's go all out to, no, I feel empowered. I want to go flat. I live a very active lifestyle. And I was very horrified specifically of some of the DIEP flap options, or where they take tissue from other parts of your body, whether it's your back or your stomach, that I wouldn't be able to do like the push-ups or the, active things I like to do because of the surgery. So it really depended on the day, right? I was empowered regardless and supported regardless, but like it was up and down, and I had the luxury of time to decide what I wanted to do. I ended up opting for a lumpectomy and then reconstruction on the other side to even things out. I don't know how you can go from small to smaller, but somehow it's possible. Um, but at the same time too, it's like, I can speak, at least for myself, it's like, I had these mantras of like, my breasts don't define me. It's okay. Like, I'm so much more of like, I'm still feminine without them. And then, you know, in tonight's conversation, I wonder where this falls. Not that there's a right or wrong, but I would just love to hear your opinion on that piece.
Well, I guess just for me, just to clarify, I didn't have breast cancer, so
Correct.
I can't speak from that position or ever understand what that feels like at this point in my life. For me, getting my breast augmentation was a very affirming surgery. And it quite possibly, when Chelsea had her procedure, could have been affirming as well. Or Chelsea, what pronouns do you use?
She, either.
Okay. It could have been a very affirming surgery for them as well. For me, I had to wear a prosthesis basically before I ever had surgery. So I know that some breast cancer patients have to wear a prosthesis at some point during or after or in the midst of whatever procedures they may have going on. For me, after I started transitioning, I was basically wearing a prosthesis for almost 3 years. And when I was finally able to have breast augmentation surgery, it was a very affirming procedure for me and made me feel whole. Like I didn't have to have something else or put something on to walk out the door and just be me.
I appreciate that. Like, I remember waking up from surgery and I was like, it's gone. I'm so happy. Like, there's just something so affirming about that. I totally resonate with that. I love that.
I think I also like a benefit of having, well, of being diagnosed with breast cancer and then also having a partner who has had top surgery. I had some idea of what, I mean, they are, top surgery and flat closure are different things.
Can you define that just very quickly, just so we have the terminology down?
Like with my, like what you said earlier, like with a mastectomy, like my partner didn't have a mastectomy. They didn't have to remove every single bit of, you know, skin tissue, like to remove something that was dangerous.
Right.
They only had to have removed what was like aesthetically going to form their chest. So then that's what my partner had, who, and then, so I had kind of, so I already knew about drains, thank God. I had already done their care. So I kind of had like a basis of some sort of idea what a flat closure could look like. I even brought it up to my oncologist when I met with her and she was talking about like mastectomy versus lumpectomy. And I was like, oh, well, my partner had top surgery. Like, how does that compare to mastectomy? And she was like, that's totally different, has nothing to do with this. And then I was like, okay, well, that's my point of reference. So can you tell me how it's different? And then she kind of was like, oh, well, like my friend, it was so funny. She started talking about her friend who's a plastic surgeon and does like gender affirming surgeries here in New York. And she mentioned Blue Bond. And I was like, oh, that's who did my partner's top surgery. Like, and she was like, you know my friend? And she was like so confused. I think she had it in her mind that her friend is like a niche surgeon or something, and like no one would know who she is. And I was like, no, she does like half of my friend's top surgeries are done by her. Like, she's very famous. Like, we love her. Like, she's a very big deal. So then like it just became like, now that I had like also a different relationship with my oncologist who was like, now you know my friend, and I'm fascinated by that. But yeah, so just like figuring out what I was able to, I think my biggest decision was what I was able to like process in the time that I was in, like the mental state that I was in. Because again, yeah, like my mental health was just like really crashed. And I just wanted to be able to maintain like as much normalcy. And I knew that flat closure was going to be the simplest option. I don't have a big I've never been attached to my breasts as like part of my identity. I've always, I had really big boobs at a very young age, and so when I had boobs, they were always for someone else to comment on. I either being teased about them or being like, just whatever gross or weird, awkward thing could happen. So I never felt like it was my body part for me in that kind of way. So losing it, it was more about like, I'm just losing like the amputation, like you said. It's like, this is my body that is like not a good thing to have in connected to me anymore. So it was more for me like in that way. And so the fear and the pressure, my mind was like in a tornado. I just was like, I wanted to be like, if I kind of started shaming myself for wanting reconstruction. So I was like, oh, well, this is because it's a tummy tuck, because it's a boob job, because of all that language. So I was afraid. And then I was like, well, I should want that. And then I was like, I shouldn't want that, because what does that mean? Like, that I need my boobs to like define my gender or my identity or anything. And I was like, look, if I want a boob replacement, if I want my breasts reconstructed, that's fine. But is that the most important thing to me right now? So it was kind of like a reverse of me shaming myself for wanting this like extra thing. And I had to like be like, that's also fine. And it's also an option, which is what my partner helped me through, was like, it's always an option for later. Like getting a flat closure, I can always go back and I can get an implant next year. I can get DIEP flap done next year, as long as, everything is still, there are certain things like I lost my nipple, but actually I wasn't going to keep my nipple anyway because of how much DCIS I had. So, there's like certain limitations for the extent of what I could have later, but ultimately, yeah, I can still do other options. And that was comforting.
I was gonna say, and there's amazing tattoo artists now out there who do amazing 3D like nipple oil tattooing. So, I think there's a lot of good options.
That tattooing was actually something that I started to look into for my breast augmentation until things kind of like settled, and then it wasn't enough need anymore.
You were looking to get that done also?
Yeah, so it's actually something that's pretty common within the transgender community as well, because a lot of people that are trans, when they have breast augmentation surgery, it may not necessarily increase the size of their nipple. So they sometimes actually use it to increase the size of the nipple that's already there for some trans patients.
For our listeners, those diagnosed with breast cancer, our allies, our friends, our medical professionals who tune in each week, what are there like, I don't know, pieces of advice or best practices or like lingering tips? I think I have a friend who always says like, what's the one word that encapsulates the conversation state?
I was going to say, because I had thought, I think that for me, it's just, that would be nice for people to understand is that not everyone who's diagnosed with breast cancer is a woman. And it's, 1 out of 100 cis men are diagnosed with breast cancer. Like, it's an expansive disease, and to remove some of this like clinging to pink ribbons and like, and if that's good for you, that's good for you, but know that it's like not good for everyone else.
And I think mine was actually going to be kind of like the counter to that, actually. I was going to say, just keep in mind that there is someone out there that's already gone through the experience that you're going through, and find that community if that's something that's of value to you.